Dear Riva Spine Alliance members, welcome to our new online education session. My name is Tobias.
I'm Robert.
And we are welcoming you today to the topic on approach selection in full endoscopic spine surgery.
Today our focus is on Middle East because we have three experienced full endoscopic spine surgeons with us, and we are very happy to have them amongst us. So I would like to introduce them to you today. And all of them, they will have a speech about full endoscopic spine surgery and the topic of approach selection in full endoscopic spine surgery. So when they do they choose transforaminal or interlaminar approach, for example? And that's why first of all, I would like to start with Dr. Badra from Lebanon. Hello, Dr. Badra.
Hello, Robert. Hello, everybody. It's always a pleasure to be part of Rio Spine Symposium. My name is Mohammad Badra. I'm an orthopedic spine surgeon. I work in Beirut, Lebanon. I have been in practice for the past 15 years, and I have been doing endoscopic cases maybe for the past 7 to 8 years. I started back in 2013, and now around 95% of my cases, either discectomy or stenosis, I do them using the endoscopic technique. So that's it.
Okay, great. Thank you very much for sharing your experience with us and our Riva Spine Alliance members. We have also with us from Saudi Arabia, Dr. Ahmend Khayyat. Hello, Ahmed.
Hi, hello everybody. Thank you for inviting me for Riva Spine. My name is Dr. Ahmend Khayyat. I am consultant in orthopedic and spine surgeon. I did my training program in orthopedic and spine in Berlin, Germany for about 10 years. Then I start also my specialty in spine surgery from the second year with Dr. Al-Zain in St. Youssef Hospital in Berlin. Then after I finished the training, I sub-specialized in endoscopic spine. I did the basic course and advanced course for the endoscopic surgery in Hernia. And then I did more than 15 clinical visits with live OPs with Dr. Rotin and Dr. Prof. I came back from Germany to Saudi Arabia September 2019. And I started also to do my endoscopic surgery in Saudi German Hospital in Jeddah.
Thank you, Dr. Khayyat.
Great, thank you very much. And also, last but not least, of course, we have Dr. Magdy Gamal with us from Egypt. Hello, Dr. Magdy.
Hello, Robert. Thank you very much for inviting me, and to see Badra and Ahmed is a great pleasure also. They are great friends and the top surgeons in endoscopic line. My name is Magdy Youssef. I'm the head of the spine unit at Ain Shams University in Egypt, and I have been doing spine surgery for a long time. But regarding endoscopic surgery, I had the chance to start about maybe 12 years ago at 2009. And I have a great chance to attend a lot of courses with Dr. Rutin, and I have seen him with Dr. Komp. And I have my experience in endoscopy actually is divided into stages. I started by transforaminal, and then I found that the interlaminar is really indicated and really needed. So I started lately to go through the learning curve of the interlaminar, and thank you for my mentors that I have learned a lot of them, like Dr. Sukumar Mahisha. Now I am actually had passed the learning curve maybe of the transforaminal and going through the interlaminar endoscopic options.
Great, sounds great, Dr. Magdy. Thank you very much. So yeah, before we start with the presentations, Tobias, some technical remarks?
Yes, sure. In case of any questions, please write them in our chat function on your YouTube, or please send them to us over email at education@rivaspine.com. Thank you and enjoy.
Yes, please, let's start now with the presentations, and you can always ask us the question, and during the presentations, we can even answer them afterwards. Dr. Badra, it's up to you. Thank you.
Okay. So hello, everybody, again. So I will focus in my presentation, as I said, as stated, on the selection criteria between interlaminar and transforaminal, when to do interlaminar and when to do transforaminal based on my experience. As you know, endoscopic spine surgery has passed through several generations. It started initially with the transforaminal approach with Anthony Young, the in-out technique, Thomas Hoagland, the out-in technique. And this has progressed later on for the second generation when Professor Sebastian Rutten introduced the interlaminar technique just to overcome the difficulties of accessing the L5-S1 disc space through the transforaminal approach because of some anatomical limitation we'll be talking about. And this has opened the door for the third generation, which is endoscopic decompression of spinal canal sheath. In this presentation, I'll focus mainly on the interlaminar and transforaminal and how do you select between them. So in general, as you know, percutaneous endoscopic lumbar discectomy can be done through two approaches, either the interlaminar or transforaminal. And when we say interlaminar, it means that we have to go through the interlaminar space. When we say transforaminal, as you know, we have to address or access the spinal canal through the foramen itself. Which way to go? Actually, at the beginning of my learning curve, it was the biggest question for me because I started doing interlaminar and transforaminal at the same time. When I have a case with disc hernia, I used to ask myself, which way to go, interlaminar or transforaminal? And this was a big question for me. Actually, the selection criteria is based on several factors, mainly the anatomical limitation of the segment you are working at. For example, if this is a primary case, revision case, the level of the disc herniation, because a disc that is present at L2, L3 is approached or is looked at in a different way from a disc at L5-S1. The location of the disc herniation, for example, a centrally located disc herniation is approached in a different way from a foraminal or extraforaminal disc herniation. And at the end, your experience, because some people are really expert in the transforaminal approach. They prefer to do any case using the transforaminal approach. And some people they really like the interlaminar approach like myself. So they prefer to do the cases using the interlaminar approach. So these factors, that you have to consider them when you decide between interlaminar and transforaminal. Let's speak some anatomical landmark in the spine. So as you know, as you go down in the lumbar spine, the size of the interlaminar window becomes bigger, while the size of the foramen becomes smaller. So the biggest interlaminar window, anatomically speaking, is at L5-S1. And when you do interlaminar approach, of course, you have to do you have to go through the interlaminar window, which means that the interlaminar approach is easiest, as you know, at L5-S1. For the transforaminal approach, the surgical anatomy, the approach depends not only on the bony anatomy, which is the size of the foramen, which has many structures like the exiting nerve root you have to take into consideration, and many vessels, but it also depends on the soft tissue window, which is the Camben triangle, as you know. And you have to understand very well the anatomy, not only of the foramen, but also the shape and the anatomy of the Camben triangle before you put your needle in order to avoid any complications. So all these anatomical landmarks you have to understand before you decide whether to go interlaminar or transforaminal. Because of some anatomical constraints, like the presence of large TP at L5, the presence of large facet, the narrow foramen, and the presence of the high iliac crest, all of these factors, anatomical factors, make transforaminal approach at L5-S1 hardest. So if you want to start your training curve with a transforaminal approach, don't select the patient with an L5-S1 disc hernia, because the chance of not succeeding going into the spinal canal are high. Maybe choose a patient with an L4, L5, or L3, L4 disc, because it's much easier to do the transforaminal approach at these levels. So in general, the indication for the interlaminar approach are all types of in-canal disc herniation. As long as the disc hernia is within the spinal canal, you can do interlaminar approach. It's easy at L5-S1. It's a little bit more difficult at L4, L5, especially if you have a narrow window, because sometimes you have to widen the interlaminar window by resecting some bone. And it's a little bit more difficult also at L3, L4, because at all time you have a narrow window and you have to widen the interlaminar window in order to get into the spinal canal. For the transforaminal approach, this is a universal approach. If you are expert in the transforaminal approach, then you can do any endoscopic case using the transforaminal approach, central, preforaminal, foraminal, or extraforaminal disc. Of course, there are certain anatomical restriction. The presence of the high iliac crest does not allow you always to go through at appropriate angle. And if you have an up-migrating or down-migrating disc hernia, you need to have some technical skills and some special instrument in order to be able to remove up-migrated or down-migrated disc hernia. Of course, the transforaminal approach, as you know, you can go either posterolateral or extreme lateral depend on the location of the disc hernia. So if you have a foraminal or extraforaminal disc hernia, you have to go to do a posterolateral approach, while if you have a centrally located disc herniation, you have to go extreme lateral in order to get able to access the disc at the center aspect of the disc and remove the herniated disc fragment. So how to choose between interlaminar and transforaminal? Of course, it depends on all these factors, but in my practice, these are the three criteria that I consider. It should be the safest approach in terms of not injuring the exiting nerve root or the traversing nerve root. So if you have a disc hernia at L5S1 and you can do it at transforaminal, but you're not experienced and you might risk the L5 nerve root, maybe it's easier to go through the interlaminar approach. It should be the most efficient in terms of removing the herniated disc fragment. So if I have a up-migrating or down-migrating disc hernia, and it's a little bit difficult for me to remove it through the transforaminal approach, maybe it's easier for me to do the interlaminar approach. And it should be the least time-consuming, which means sometimes when I have an L4, L5 disc hernia, preforaminal, not up-migrating, not down-migrating, of course I can do it through the interlaminar approach, but in the transforaminal approach, I can do it in like 15 minutes. So why to do the interlaminar approach when I do the same surgery using the transforaminal approach in less time? So what I will mention right now are the criteria that I use for 90% of the cases, 90% of the disc hernias that you encounter in your clinical practice at L4, L5, and L5S1. And you have here 6 scenarios. So if I have a disc at L4, L5, which is not migrated, it's not up migrated, not down migrated, at the level of at the same level of the disc. So my preference is to go through the transforaminal approach. This is based on my experience. Maybe not all of you will agree, but this is what I do in my practice. If I have a down-migrated disc hernia, of course, you can do it through the transforaminal approach, but in order to be able to remove the herniated disc fragment, you have to get at a certain angle, which might put a risk at the exiting nerve root. And you might, if you're not experienced, you might put a pressure on the exiting nerve root and the patient might wake up with paresthesia. And I think Dr. Magdy will show a case about this issue. So in these cases, when I have a down-migrated disc, of course, you can use special instrument like flexible instrument or like Schwa suggested, do partial pediculectomy, or some people in Germany, they go through the pedicle, transpedicular endoscopic discectomy for down-migrated disc hernia. I think this is technically demanding, and you need to have a good experience with the endoscope in order to go through the pedicle to remove the herniated disc fragment. This reminds me of the transiliac approach for L5S1, which we used to practice initially, but I mean, we're not using it anymore. But this is a way to go around a down-migrated disc hernia. So for a down-migrated disc hernia, I prefer to do it through the interlaminar approach. For up-migrated disc herniation, of course, you can do it through the interlaminar approach, but here you have to resect a good part of the bone, of the lamina, in order to be able to access the disc, herniated disc. And because I don't have the problem with the exiting nerve root here, I prefer to do it through the transforaminal approach. For L5S1, because of all the anatomical limitations that I spoke about, if I have, as long as the disc is within the spinal canal, I always go through the interlaminar approach. If I have foraminal or extraforaminal disc hernia, at L5S1, I will go through the transforaminal approach. So as you see here, out of the 6 scenarios that you might have at L4, L5, and L5S1, in 70% of the cases, I use the interlaminar approach. In 30%, I use the transforaminal approach. But if you're, I mean, it doesn't have to be this way all the time, because some people, as I said, are really expert in the transforaminal approach, and they prefer to do all cases using the transforaminal approach. I will show you some of my cases just to show you how do I select between interlaminar and transforaminal when I do interlaminar and when I do transforaminal. Look at this case. This is a big disc hernia at L5S1. For me, I don't think of transforaminal. I always do L5S1 interlaminar as long as it is within the spinal canal. And you can see here that the disc was removed, and you can see the nerve root, the dura, you can see the rent in the disc, in the annulus. And these are the pre-post-op for the same patient. Down migrating disc hernia at L5S1, again here, always I do interlaminar, whether up migrating, down migrating at the same level of the disc. At L5S1, I always do interlaminar approach. This case was done using the interlaminar approach, and this is an axillary disc hernia that was removed totally. Go higher up at L4, L5. It's a preforaminal disc hernia at L4, L5. Of course, you can do it interlaminar. It's easy to be done interlaminar, but why to do interlaminar when you can do it quickly with a transforaminal approach? So in these cases, I like to do it transforaminal. So I put my scope in, and believe me, if you put your needle at the appropriate location, the whole surgery will take only 15 minutes to remove the herniated disc fragment. Look at this patient. This is another patient who was operated before with laminectomy. This is an incision in his back for a centrally located disc hernia. So in these cases, I'm sure I mean, we're doing interlaminar for revision cases. That's true. But why to use the interlaminar approach here for a centrally located disc herniation when the transforaminal approach is a version route and you can do it through the transforaminal approach? Look at my working cannula here. It's almost parallel to the floor. I'm using here the extreme lateral approach in order to be able to get to the central aspect of the disc. And as I said, when you put your needle at the appropriate location, you will be able to remove the whole disc as a one fragment, and the patient is cured in the same day.
Mohammed, can I ask you something?
Please.
In the last case.
Please, yes.
Actually, this case is the beauty of endoscopy. In a case like this with the laminectomy before, usually the patient is offered open fixation screws and that's it. I'm asking you about, on the slide on the right side, you have seen this arrow going through the foramen to the fragment. Do you prefer to do some sort of foraminoplasty with the burr?
Yeah, if it goes in my way, I will do it. But here in this case, frankly, Magdy, I didn't have to do anything. It all depends on your starting point at the level of the skin. You have to study the MRI very well and to know where is the location of the disc hernia. And believe me, in this case, I didn't have to do any bony work. So I look at my working cannula. That's what I mentioned. It's almost parallel to the floor. I mean, it is not a posterior lateral, it's only extreme lateral approach, and that's why I didn't have to do any bony work in this patient.
Okay, thank you.
What about this case, Magdy? And this is a down-migrating disc hernia just behind the pedicle of L5. So how will you do it, Magdy? It's transforaminal or interlaminar, based on your practice?
Down migration, I think interlaminar is safer.
Yeah, I mean, it's behind the pedicle. This hernia is just behind the pedicle. I mean, some people, as I said, suggested to open a hole in the pedicle to go and remove the herniated disc fragment. And I don't know what's the advantage of this technique. But here, I did a small laminotomy at L5. Just this is a nerve root, and I knew that the disc hernia is just under the nerve root. So here I can put my forceps here and remove the herniated disc fragment as a one piece. And you can check under the nerve. You can see under the nerve. I mean, with the transforaminal approach, I'm always afraid that I'm leaving a small part of the fragment. But here I can check the nerve. I can move the nerve. And I can make sure that I'm not leaving any fragment just under the nerve. This is the beauty of the interlaminar approach. I mean, and transforaminal is a very, very good technique, but I mean, you should know, you should have experience with it, and you should know when to use it for your cases. This is another patient, L4, L5. When I looked at this patient, I mean, Magdy, how would you do it also again? L4, L5, transforaminal or interlaminar? I mean, this is appealing for transforaminal because when I looked at the MRI, I said to myself, I will do it transforaminal for sure, right?
I would do this. I would do it transforaminal.
But look, I always do an X-ray before I do my surgery. And when I looked at the X-ray, look at the X-ray for this patient.
The crest is very high.
Look, the iliac crest are very high, and look at the disc space is collapsed, and the foramen is narrow. look at the difference between the foramen between L4, L5, and L3, L4. And when I looked at the AP, look at the interlaminar window. It's a huge interlaminar window. I mean, you don't have to do any bony work. So I decided, this is a patient, 140 kilogram. So I decided to do him through the interlaminar approach. And believe me, I didn't do any bony work, nothing. I mean, I didn't have to resect part of the lamina in order to be able to go inside the disc. And I was able to go inside the disc space and remove any loose fragment from this disc space. Look at this patient also, L4, L5, L5, S1 in the same patient. I have encountered like, I think 4 or 5 cases, similar cases where I have to operate on both levels. So L4, L5, L5, S1 on the same segment. So what to do? So for this patient, I still apply my criteria. So I did L4, L5, I did the transforaminal approach, and L5, S1 interlaminar approach in the same setting. And the patient ended up having only 2 stitches, one for transforaminal for L4, L5, and one interlaminar for the L5, S1. Let's go higher up.
Dr. Badra, excuse me, Dr. Badra, yeah, before you go to the next case, just one question from our side. If you can, this very interesting case. We have often this discussion in Germany when we do operate 2 levels, let's say, of disc herniations, whether you check before if both segments are symptomatic. Is this the case here, or how did you decide, that you need to do both? Because
it's based on the clinical exam. It's based, Robert. It's based on the clinical exam. I mean, the
so both were symptomatic.
And he was symptomatic from both. From both levels, L4, L5, and L5, S1, the L5 nerve root and the S1 nerve root. So I was afraid to do one level and leave the other level. The L4, L5, it's always when you're experiencing it, it's a quick procedure. So I started with the L4, L5. 15 minutes, I was able to remove the herniated disc fragment because it depends on the landing point. And then I went to do the interlaminar L5, S1, which again, it takes like half an hour. So both levels will take less than an hour to do them. So yes, but based on the clinical exam, Robert.
Okay.
So let's go higher up at L3, L4. Down migrating. Again, Magdy, sorry, Magdy, I'm asking you always. You're our mentor. Interlaminar or transforaminal?
I think in higher levels, the interlaminar is a bit difficult, Mohammed.
What do you think? Excuse me, Dr. Badra, if we open the discussion to Dr. Khayyat, what is your opinion? What would you do here?
Dr. Khayyat, what's your opinion?
Yeah, my opinion to do it interlaminar and to do the skin incision, the upper part of the interlaminar window, and to go oblique to the disc. I will do it interlaminar.
And do you think you will require drilling here, or do you think it will? Yeah.
You always require drilling at L3, L4. You always. But look, when I started using the stenosis scope, I mean, the spectrum became very wide because I can do interlaminar even at the higher level, L2, L3, L1, L2. Because what I use for these cases, I put my stenosis scope initially. I do burring and use Carison like the open technique. And then when I want to go inside the canal, I do exchange tubing. So I exchange from the stenosis scope to the narrower scope, the regular scope, in order to be able to go inside the spinal canal. And this case was done using the, I'm sorry for the video, but this is the interlaminar approach, and I was able to remove the herniated disc fragment using the interlaminar approach. Let's go ahead.
Mohammed, if this case was not down migrated, would you do the same?
I will do it transforaminal, of course. But I'm afraid for down migrating disc hernia, if I go through at a certain angle that I will injure the exiting nerve. I will put the pressure on that. But I mean, this can be done, and a lot of people do it through the transforaminal approach. I totally agree, but I mean, this is how I do it. This is I combine the safety with the efficacy with the time limit. So all of these factors I take into consideration before I decide whether to go transforaminal or interlaminar. So look at this patient, L2, L3. Of course, I cannot extend my leg and do it. I mean, I can do it interlaminar, but it's much easier to do it transforaminal in this case at L2, L3. So why to go interlaminar, right? You can do it interlaminar, but it's easier to do transforaminal. And here, I'm putting this case just to show you that at higher level, you don't go extreme lateral not to injure the abdominal structure. You go posterior lateral, and this is the case. Just put your needle at the appropriate location, and you will be able to remove the herniated disc fragment as a one piece. And this patient developed what's known later on as post-discectomy pseudocyst. It's beyond the scope of this presentation, but he improved later on. Several studies actually compared interlaminar to transforaminal. These are the three last slides, and all of them they showed a good outcome either using the transforaminal or interlaminar. In this study about L5S1, they showed that the fluoroscopy time and the operating time were significantly better in the interlaminar approach. Again, for this article talked about the L4, L5, which showed that similar good clinical outcome, but the operating time and the radiation time were less in the interlaminar approach. And this is the last slide. This article compared the transforaminal and interlaminar regarding the complication, and what this article meta-analysis study showed that the complication rate, mainly the dural tear, were higher in the interlaminar approach. And this is logical because when you are using the interlaminar approach, you enter the spinal canal, you put your scope in, you retract the dura, the nerve root, and there is a little bit higher chance of injuring the dura. But this is not a problem because I have encountered dural tear with the interlaminar and with the transforaminal approach, and this is should not be considered an obstacle because most of these patients, they don't usually require intervention, and most of them, they will do well. So thank you.
Great, yeah, wow, Dr. Badra, we are very impressed, really, very nice presentations, really nice graphics. That is really, I think the audience likes it very much because in our point of view, your approach selection is very clear to us here, it's very clear. Nevertheless, of course, we have some questions from the audience, Dr. Badra.
Yes, Dr. Badra, from Mr. Mustafa Kandil. He's asking, to reach the central disc, can you define the most far point for the entry to be still in the safe zone?
Yeah, but I follow the recommendation of Dr. Rutin. So on the lateral X-ray, I don't go below the facet line. So I don't go below the facet line in order not to, this is the safest zone. But the more centrally located the disc, the more laterally my starting point is, as I told you in one of my cases. If I have a foraminal or extraforaminal case, I go posterior lateral. But if I have a centrally located disc, I should be as lateral as possible. Sometimes it depends on the size of the patient, but sometimes I choose anything between 12 to 14 centimeters from the midline. But I don't, on the lateral X-ray, I don't go below the facet line. This is my safest landmark.
Okay, yeah, clear to us. We have another question also, Dr. Badra. The question was, why not doing L4-5 interlaminar?
Why don't do 4-5 interlaminar? I always do 4-5 interlaminar, but I said, if you have a narrow window at L4, L5, and you can do it interlaminar, of course. You have to resect. You have to widen the interlaminar window. You have to resect to do some bony work, resect part of the bone to widen the interlaminar window before you go in the spinal canal. So of course it can be done. I like the interlaminar window. Most of my cases I do them interlaminar. But in these cases at L4, L5, if I'm able to do it through the transforaminal approach, it's much less time. It takes me less time and it's much easier. I don't have to do any bony work. I can put my needle at the appropriate location in the Camden triangle, and in 10 to 15 minutes, I'll be done with my surgery. So these are the criteria that I mentioned. The time is important here. So if it takes me 1 hour to do the case and 15 minutes, I will choose a 15-minute approach rather than a 1-hour approach.
Absolutely, yeah. And if you have the iliac crest, as you described in your presentation, that is too high, of course, you would take the interlaminar in that case.
So all these factors I take into consideration before I decide interlaminar or transforaminal.
Yeah. Okay, I think thanks so far, Dr. Badra. I would suggest that we continue the discussion afterwards. We would switch over now to Saudi Arabia, to Dr. Khayyat, and we are very interested to looking forward to his presentation. Dr. Khayyat, please. Yes, go ahead. You can start.
Okay, next. Yeah, next slide. So my presentation would be about endoscopic discectomy and decompression of lumbar spine. First, I'm going to talk about the two different endoscopic techniques. We have endoscope-assisted system. It's like the microscopic surgery, a small incision, but you insert the retractor, the fixed retractor, and the fixed camera, and you have the mobile instrument. And we have also the full endoscopic system. It's a smaller incision, it's about 7 millimeter, with full endoscopic techniques, with full irrigation system, and full flexible camera and instrument. Next. What is the full endoscopic surgery? The full endoscopic surgery is defined as a technique that for the spinal canal and nerve structure using a continuous irrigation and visual control using a very minimal approach with the uniportal technique using an endoscope with intra-endoscopic walking channel. We have different approaches. We have the classic dorsal interlaminar approach and lateral transforaminal and extraforaminal approach. So the standard approaches, as you can say, the interlaminar approach using the interlaminar window and the lateral using the foraminal approach. So which approach do you use? Interlaminar or transforaminal? So in the next slide, I will explain which approach you use. Actually, more than 70% of the cases is the intraspinal lesion, interspinal pathology, and 90% in the L4-5 and L5S1 disc space. So 70% of the cases we use an interlaminar dorsal approach, and 30% use the lateral extraforaminal and transforaminal approach. So for the lateral approach, we have the posterior lateral with 45 degrees, and this we use for the intradiscal pathology. The lateral approach for the medial pathology and medial lateral pathology is about 15 degrees, far lateral, and next. And we have an extraforaminal approach for the extraforaminal pathology and foraminal stenosis. Always be careful for the lateral approach. Do a pre-op MRI and to see if you have a higher level pathology. Be careful for the kidney, and if you go down, look also for the iliac crest. This is an example for the transforaminal approach. As we can see here in the 6 o'clock, the disc space, and now we are cutting the horizontal structure, the PLL, piece by piece, until you can see the pathology medial. And this is the layers of the PLL, removing with the scissor. And this is the pathology here, the intradiscal, the interspinal disc prolapse. And this is after removal. If you go more medial, you will see also the traversing nerve root and the epidural fat. And here down in the 6 o'clock is the disc. And now here in the middle is the traversing nerve root, and above it the epidural fat.
So Dr. Khayyat, just one question here from the audience. Do you need to cut the PLL always?
Yes, to see that if the pathology is intraspinal, you should cut the PLL.
And if not, you keep the PLL in place, or what do you do?
Yeah, if the pathology is extraforaminal, is outside the spinal canal, you don't need to cut. So I go extraforaminal.
Dr. Badra and Dr. Magdy, you do the same, or do you differently?
I mean, I always go for the pathology. If I'm able to remove the pathology without cutting the PLL, I don't have to cut the PLL. So it depends on the location of the disc hernia. So I don't have to cut the PLL all the time. If I put my needle at the appropriate location and remove the herniated disc fragment, I'm done.
Okay.
I don't have to see the nerve root all the time. I mean, if I've removed the pathology, I'm satisfied.
Yeah. Okay.
For me, I like to cut it because the fragment itself sometimes is very difficult to remove easily if it's still in place. When you cut it, you free the fragment so that you can easily remove it. And I prefer to see the root, at least the pulsating traversing root, the dura. I prefer to see them and to see the pulsations after full removal of the fragment.
Okay, interesting. Yeah, let's continue the discussion afterwards. Yeah, Dr. Ahmed, yeah, you can go on.
Okay, so this is the anatomical structure after removal of the pathology, the rest of the PLL, traversing nerve root, epidural fat. If you go more medially, you can see also the dura. For the extraforaminal pathology, we use the extraforaminal approach. You shouldn't go to the interspinal canal. You do this approach also bilateral for the extraforaminal disc herniation and foraminal stenosis. Okay, next, this is also to protect the nerve. So this is an example for the extraforaminal. As you can see here in front of us, also the pathology. And at 4 o'clock is the exiting nerve root. And we're trying to protect it with a walking sleeve. As you can see here now, the exiting nerve root, now protecting with the walking sleeve and removing the pathology.
So now our nerve root is just, we can just see it.
Yeah.
You see it?
Yeah, now also the nerve roots are protected. Now in front of us is only the prolapse.
Here it is again,
and this is after removal. Yeah, this is after removal. And we can see also the exiting nerve root.
So here the cannula, everything is a little bit tilted, so the direction is a little bit different.
So now I'm going to talk about the interlaminar approach. Yeah, Dr. Rotten invented and developed also this approach for the full-endoscopic. As we can see, as I said before, 70% of the cases is interlaminar. So you go through the interlaminar window. And this is the view from the intraoperative, and you can see also the dura and the nerve root in front of us. So this is an example how to start the seizure, the interlaminar full-endoscopic. We're starting by open the flavum, starting from medial, and turn the scissor toward the lateral. Now the spinal canal is open. Now turn the scissor lateral toward the facet joint. And also you don't need to do full flavectomy. It's only a canal, small canal also is enough for this walking sleeve. And you can see also at 4 o'clock is the synovium from the facet joint. And now to identify the nerve structure after removal of the epidural fat with the punch.
Can I ask something, Ahmed?
Yeah, please.
Yeah, sometimes when you do interlaminar, you find the disc is very big and it is pushing the whole neural structures up toward the tube. And do you prefer in this case just to start removing piece of the disc to allow the tension on the dura to be less, and this allows you to rotate the tube, or you try still to rotate the tube around the root?
I prefer actually to do more decompression toward the lateral. Also, if you remove from the ascending facet for more space, and then you can rotate your walking sleeve.
Okay.
Okay, this is after flavectomy and removal of the epidural fat, and we can identify the nerve structure. We can see the dura and also the nerve root. So this is step to push the walking sleeve to protect the nerve structure. So first pushing to the ground, and then rotate clockwise or anti-clockwise as possible. Now the nerve structure is completely protected, and you can see in front of you the pathology. This is the prolapse.
And do you always do this maneuver, or is this, for example,
Yes.
Doctor, always, yeah? And what about the
Always.
case, as Dr. Magdy described, if you have a really very big herniation, and you have no space, for example, to do that. Do you keep outside? Do you stand on the bone, or what do you do?
Yeah, you can with the dissector also do release. And if you see the tip of the disc, the part of the disc, you can also remove it. But I prefer to decompress more laterally and also to remove part of the facet joint to do the rotation maneuver.
Okay.
Okay, this is also to explain how to rotate and to protect the nerve root. Now the next step is to remove the pathology, cutting the last layer of the annulus. And remove the disc with the punch. And you can always also do intraoperative X-ray to see where you are.
And there at 12, at between 12 and 9, we see 3. We see a little bit neurostructure, correct? Here.
Actually, the nerve structure. Yes, this is the nerve structure. Apart from the nerve root. Okay, we can do also a full endoscopic decompression, starting by to do release between the descending facet joint and also the flavum ligament. You shouldn't open the flavum ligament at the beginning. Try to do space for the burr between the flavum and the descending facet. So we're starting the drilling, starting from the descending facet and go up to the lamina. The aim for that is to see the tip of the ascending facet. So now starting with the drill. This is the descending facet, the middle part of the descending facet, and to go up to the part of the lamina. And always do intraoperative X-ray to see where you are. And we can see now in the deep, the part from the ascending facet. Now you can just thinning the flavum ligament to see more from the part of the ascending facet. So now this is starting the drilling from the tip of the ascending facet, going laterally and caudally.
So this is what you do just in ipsilateral decompression.
In ipsilateral, yes. Yes. And you can also use the Carson. Now we can open the flavum ligament to see the neural structure, and you go more lateral toward the foramen.
Nice.
Okay, this is after decompression, and you can see also the floating signs of the dura, the signs of decompression. And you can also do the contralateral decompression through the endoscope. So what is the algorithm of the lumbar decompression? If you have the foraminal stenosis, so you use the foraminal decompression from the lateral approach. If you have rectus stenosis or central stenosis, use an interlaminar decompression using the drill and Carson. So in a summary, which approach do you use? The transforaminal, extraforaminal, or interlaminar approach? As you go more caudal, you have a big interlaminar window, so I prefer to use the interlaminar approach for intradiscal pathology. And if you have also the extraforaminal pathology, you use the extraforaminal approach. As you go cranial, the interlaminar window is getting narrower, so it's better to use the transforaminal approach. So recommendation for the beginner case, if you want to start with the interlaminar, choose first your patient with L5S1 disc and big large interlaminar window and paramedian herniation, and also the herniation shouldn't be so big and also not located cranially or caudally. For the transforaminal approach, look always for the iliac crest, choose the level L3-4 or L4-5 with a large foramen. This is case done 6 months ago. This patient is a 26 years old male patient, have disc prolapse L5S1. This is how to start the surgery. You will see first the fascia and cleaning the fascia and the muscle, and then starting to open the flavum ligament. So always when you cut with the silver razor, turn the endoscope to the lateral and to see what you cut.
So now, Dr. Khayyat, where is now lateral?
Now lateral is around 10 o'clock. I mean medial is 10 o'clock and lateral is about 4 o'clock.
Mm-hmm.
So this is the last layer from the flavum ligament. It looks gray. And when the flavum is open, turn the scissor toward the lateral, toward the facet joint. And as I said, if I'm not sure where the nerve structure, I go more lateral to be sure, and to remove also the last layer of the flavum ligament that attached in the ascending facet. Now identification of the neural structure, removing the epidural fat. And here is some bleeding now happening, and bend it with the cautery. So sometimes you see a lot of adhesion between the disc and the nerve structure. Always do the release with the dissector to be easy to do the rotation maneuver with the working sleeve. Now push the sleeve toward the ground and then rotate. And you can see now the nerve structure is protected with the sleeve, and you can safely remove the disc prolapse. Okay. Next slide. So this is case for discussion. This case came to me last month in the clinic. She is 36 female patient complaining from severe sciatica in the left side, and she has this very big sequestrated disc almost to the S2. So, Dr. Magdy, what you prefer to do? Do it interlaminar, or also you will choose transforaminal approach for this kind of prolapse?
No, I think Ahmed, it's interlaminar is the best for this case.
And any tip? Sorry, any tip how you would do this interlaminar as a usual interlaminar, or would your incision point be a little bit different than usual?
Actually, yes. The incision, it should be cranial as usual, and then to do also decompression from the lower lamina. Okay, start the video, the next.
Sorry, and Dr. Badra, you agree, yeah? Dr. Badra, on the point.
For sure, for this patient, I will do interlaminar. I prefer to do interlaminar in this case. Even if I have to do partial laminotomy from the S1 lamina, of course, but I will do it interlaminar in this case.
Okay, thanks.
Okay, this is after removing of the flavum. You can see the dura and the nerve root. So I'm trying now to do decompression from the S1 lamina to go more caudally and to catch the prolapse.
Can you orientate us here, Dr. Khayyat?
Yes, at 12 o'clock is medial, 6 o'clock is lateral, 3 o'clock is cranial, and 9 o'clock is caudal. Mm-hmm. This is after decompression, and we are now in the axilla. Mm-hmm. I'm trying now to catch the prolapse. It was actually huge collapse. You can see now the signs of decompression. The dura is pulsating.
Mm-hmm. So one question here, Dr. Khayyat. Did you go afterwards also lateral of the nerve or not?
Actually, in this case, no, because the sequestrated disc was in the fovum. So you need to go in the axilla. You don't need to go.
Mm. So you were sure there was nothing. Okay. Mm-hmm.
Okay, finished. Thank you. That's all.
Thank you, Dr. Khayyat, for your presentation. So before we start with the next presentation, we have some questions we would like to ask from our audience. First question is the interlaminar approach suitable for a foraminal disc herniation at L5-S1 when transforaminal approach can't be done?
You mean for the extraforaminal disc prolapse in L5-S1?
Yes, I think the question is about, I mean, in foraminal disc herniation in L5-S1.
Yeah, in L5-S1, if the disc prolapse is in foraminal or extraforaminal, you should go also extraforaminal, even for L5-S1. You go oblique to the iliac crest and to reach the foramen of the L5.
Dr. Badra, would you please also?
Yeah, I totally agree. If you have a foraminal disc or extraforaminal disc, I will go transforaminal. Nowadays, with the stenosis scope, as I said, it expanded our limits, and we can do partial fascicectomy with the stenosis scope and do burring of the facet. But why do you have to do it if you can do it through the transforaminal approach? So as I said, the indication for interlaminar is intracanal disc herniation. If I have a foraminal or extraforaminal, I go transforaminal.
Mm-hmm. Thank you very much. And we have to you, Dr. Badra, the next question. For the case of the disc herniation on both levels, L4, L5 and L4, S1, why don't you perform in 2 levels via interlaminar approach?
Of course, I can do it interlaminar approach in the same level. I have to do different incision, right? So I have 2 incisions, 1 incision for the L5, S1, 1 incision for the L4, L5, in order to have a proper angle. You can do it, but I thought it is quicker to do the transforaminal approach of L4, L5, where I don't have to do any bony work, put the needle in the cambial triangle, remove the herniated fragment, and do interlaminar at L5, S1. I mean, some people will do both transforaminal at L5, S1, L4, L5, and some people will do both interlaminar at L4, L5, or L5, S1. You can do whatever you like to do. But I put this case to show you that in the same setting, you can do interlaminar and transforaminal in the same patient. So if you're happy with the transforaminal approach, you can do both levels using the transforaminal approach, or you can do both levels using the interlaminar approach. It's the same. I mean, you choose the way you feel easy to do. So that's fine.
Yeah.
Thank you.
Yeah, thank you. And it's really impressive patient or impressive surgery that you showed us, a case. We have another question about decompression, and I think Dr. Khayyat has spoken about decompression in his presentation. So the question is actually about the advantages of doing this decompression over the top, with decompression, full endoscopic decompression set, instead of doing this with a tube. Dr. Khayyat, what is your advantage doing this?
Yeah, for the undercutting over the top, using the full endoscope, you can see also the nerve root from for the other side.
Mm. Yeah, and Dr. Magdy, you have any experience on that, or do you see any advantages on that?
No, I actually agree with Ahmed. It's the same answer.
So,
if I may comment, Robert,
please,
actually, before I started doing endoscopic decompression for stenosis, I started using the tube first, and this is a good technique to learn decompression for stenosis. But look, for the endoscopic, to use the endoscopy for stenosis, your eye will be inside the spinal canal. While if you are using the tube, your eye is outside the spinal canal and you're looking inside the spinal canal. I think it gives me more precision if I put my scope using my scope in and look at I can do ipsilateral and contralateral decompression. I mean, you can start with a tube, you can teach yourself how to do it with a tube, and then you can move to the smaller tube, which is the endoscope. That's fine.
Yeah, sounds logic to me. Okay, so let's move to the last presentation. Yeah, Dr. Magdy. Before we start with your presentation, just for the audience, this is a very nice, I think, case discussion that Dr. Magdy brought with us, and especially, I think, yeah, many cases also are done together with his Indian friends, but I think he will comment on that. Yeah, please.
Okay. Yeah. Thank you very much. Thank you, Robert. My name is Magdy Youssef. I'm from Egypt. I'm at Ain Shams University. Yeah. Thank you very much for my friends Mohammad Badra and Ahmend Khayyat for the nice presentation. Actually, they covered everything, and it's a pleasure to join them in this meeting. Thank you, Dr. Rutten, for his continuous support and illustrative drawings, and I take this opportunity to thank my great mentors, friends, and brothers, Dr. Mahisha and Dr. Sukumar, for their continuous teaching support, and they visit me a lot, and they changed my impression, perception, and directions in this endoscopic surgery. This is the first case. It's a straightforward case. It's a 48-year lady with severe leg pain on the left side, no instability. She took a lot of medical treatment, a lot of other methods of conservative treatment, but she is not happy. Okay, let me ask Badra, what do you think? Because you like the interlaminar
I mean, you can do it both ways, but for me, this is a clear indication for a transforaminal approach. It's a 4L5, you're saying. I mean, I suppose I don't have a problem with the iliac crest. It's a centrally to left paracentral disc herniation, so you can do with a little bit extreme lateral approach. You can go in and remove the herniated disc fragment easily. You can do it interlaminar. For this patient, I prefer to do it through the transforaminal, of course.
And Ahmed, do you have the same decision?
Yeah, I have the same decision because the interlaminar window actually is narrow, so I prefer to do it transforaminal.
Yeah.
And to all of you, Dr. Magdy, sorry, just to all of you, just one question. Do you look at the size of the foramen in case, or is this, you don't care about the size of the foramen? Because you will say, okay, I will increase it with our manual or our motor control drills, or is this also playing a role in your decision?
Of course, the wider the foramen, the safest the technique, but you can always under vision use the burr and remove a part of this facet joint, and then you can correct the tube to be on the horizontal direction again. So yeah, I sometimes burr the facet just to reposition the cannula to be on the horizontal level. Okay. So this red line is actually this red line is the Badra commented to this red line. This red line is on the facet line. This line changed my life because anterior to this line it is very dangerous. You might injure some visceral structures. You have to stay posterior to this line, and this white line is the spinous process line. So I think the safest is to go. In the beginning, you better be near to the white line. When you advance your surgery and learning curve, you can go towards the red line, but don't cross this red line. I put this yellow line to tell you something very important. When I started this technique, I usually use this posterolateral exposure, and this is not practical in cases like this because simply the cannula itself will be this joint that will act as a fulcrum. It will push you to the center of disc. You can never reach the fragment. So the safest and the best in this case, as Dr. Badra said, is the far lateral exposure. Is the next, please, the green line. This blue one is very dangerous. It's anterior to the line. So I prefer always this green line to reach the fragment as Dr. Badra proposed. Next, please. And you see here, this is the fragment, and this is the dura pulsating here, and at 6 o'clock is the disc after removal of the fragment, and you see it was very big fragment. It came into pieces, and it improved immediately after the surgery. Any comments, Badra?
Yeah, that's excellent. Very good job.
Okay. Okay. This is a case similar to Dr. Badra's case. This is a young man. I think he was 18 or 19 years old. He had also 4-5 disc and L5S1 disc, both levels. Actually, in this case, I decided to do like Dr. Badra. I prefer to do the L4-5 transforaminal. And this is after finishing the removal of the fragment, and this is what I have talking about. I like to see the pulsations of the root and the dura, and then for the L5S1, I have chosen the interlaminar. And in this case, you see here, I was learning the interlaminar. Dr. Mahisha was teaching me how to do the interlaminar. Actually, in the beginning, I thought it's difficult, and I was really frightened to start it. But once I start this interlaminar, actually, it solved a lot of my problems, because I was always insisting to do transforaminal in L5S1 because I was perfecting the transforaminal. But I had a lot of bad results because of the direction, oblique direction. So these L5S1 cases, I always decide now to do by the interlaminar exposure. Next, please. And this is the case here. You see, I found a big piece in the beginning. So I always prefer to remove this piece to lower the tension on the dura and the root. And that allows me, in the next slide you will see, allows me the magic movement of the tube. When you rotate the tube itself, it acts as a retractor for the root. And it gives you a safe zone to remove the other part of the disc. If the disc is tensioning the dura, it is very dangerous. You can injure the root and the dura during rotating the tube. It was a very big fragment at L5S1, you can see here. Okay. Yes. And this is the post. You can see here, immediate post-operative. You can see here the full decompression. And there is another X-ray after about, I think, 3 months. Next, please. Yeah, and this is after 3 months. And the good thing is when you see the MRI after about 3 months or more, you find some sort of remodeling of the disc. You look as if he is not touched before. This is the magic of endoscopic surgery, as you see here in the post-operative. This is L5S1 disc. These, as I told you in the beginning, I was keeping myself away. I don't know why. I was keeping myself away from the interlaminar. But then I started doing. Thanks to Dr. Mahisha in this case, he was teaching me. See? Yeah. I think there is a video here.
Just a second, trying to run it.
Yeah. Yes.
So this is already.
Excellent vision. You see everything.
So this is the shoulder. Yeah, there is.
Yeah, this is the shoulder of the root. This is the axilla, and this is the dura, and this is the disc removed. Actually, I am proposing interlaminar for all L5S1 discs, unless it is, of course, extraforaminal or something. Okay. This is the post. You can see here the fragment is completely removed, and the patient is immediately discharged. Another case. This is the disc L4-5. But you see here, this is the point of Dr. Badra. Dr. Badra was pointing out at the iliac crest. I will show you something in the next slide, please. I decided to do transforaminal, but see here in the upper part, my direction was not parallel to the disc. I thought I will start from cranial to caudal to get the fragment better. The patient is okay, but what happens is he had severe pain from the exiting root. And this point is very important, because I was asking once Dr. Rutten, I was in Germany with him, and he showed a case in one of the courses. And I asked him, if the disc is migrated down, why should I go parallel to the disc? I should go from cranial to caudal to in the direction of the disc to catch it. And then he said, never do this, because suddenly you will actually, in your direction, you will catch the existing root before you reach the foramen. And this is, I have seen this practically a very, very important point. Don't do this, especially in down migrating cases. Okay, this is another case. This patient is a young patient. I think she was 27 years old, and I did before a discectomy, open discectomy for this patient years ago, and she came to me with this recurrent disc at L4-5. Badra, what do you think? Would you go in recurrent cases? Would you again do interlaminar?
No, for this patient, I prefer to do it transforaminal, as I said. If this patient has been previously operated, so I prefer to do it through a transforaminal. It's not so much down migrating disc. So I mean, you can remove it using the transforaminal approach.
What about in general? Yeah, sorry.
Yeah.
So just in general, maybe the question also to the audience, also Dr. Khayyat, about recurrences. Of course, we have always the question, okay, how do I treat recurrences? I think Dr. Badra has shown very well in this presentation that he sees the big advantage, of course, of somebody being operated, having conventional surgery before, and he has a recurrence, and he did it in transforaminal, so he did not need to pass through all the incisions and the prior surgery. What in the case if you have, for example, recurrence on L5S1, and would you absolutely do this somehow transforaminal? I don't know how, or would you in this case opt for interlaminar, even though he was done either interlaminar before, prior, or conventional? Maybe Dr. Khayyat?
Actually, I prefer to do interlaminar, even for in the same side on the same level.
And you have no problems with scar tissue?
No problem. You can first recognize your bone, and you can go to the lamina, to the rest of the lamina, and you start from there, from the normal lamina to the normal bone, and then go to the nerve structure.
Okay, excellent.
For me, actually, I think I feel very safe to skip this previous scar and to go transforaminal to avoid reaching these adhesions, actually. And this case,
but yeah, sorry, Dr. Magdy, but in L5S1, in L5S1, I mean, we understood the logic, of course, Dr. Badra says, and you go, of course, lateral if you can, but what if you cannot? Yeah, what do you do?
In 5S1, I wouldn't do transforaminal.
Okay.
I stopped doing transforaminal in L5S1. So this is the case you have seen here.
Lost connection.
But it was adherent. Hello?
Yeah, would you please repeat once again? The connection was lost for a second.
Yeah. Can we open the videos? Yeah, this is showing that it was excellent to remove it transforaminally. You see here, I tried to dissect the adhesions here on the left side, but it is adherent, very adherent to the dura and the elliptic disc, and full pulsations, and the patient was very happy. Actually, she was offered to have open discectomy and fusion. She is 27 years old. She escaped the fusion, which is the beauty of endoscopic surgery in young patients.
And can you, Dr. Magdy, show us the trick you did? If you can see the video again, please. You did to see if the nerve is or the nerve structures are released. What do you do there on the right side?
This is a hook, like a probe.
No. On the right, on the right side, you see the pulsation. Yeah. There is a certain trick that you apply with the irrigation. What do you do exactly? To show
irrigation?
Yes.
I think you put your thumb to.
So actually, you close the outflow during certain.
I close it and to see the pulsations. Yes.
Yeah, that's a nice trick actually. For the participants to see. Thanks.
Yes. Yeah. Thank you, Robert. This is the post-operative and excellent post-operative, and she is very happy. And I'm very happy that I was not obliged to do fusion, because you see the disc of L5S1 is not 100% healthy, which means that in few years she will come again for another fusion at L5S1. Yes, next case, please. This is the post-operative. Sorry. This, I think this will summarize my view now, after starting learning the interlaminar. Before this, I wouldn't have said this, but now actually I learned the importance of the interlaminar exposure in endoscopic surgery. Next, please. I think if the, can we click on the next? Yes, and the other one? I think if I can see, no, the previous one, please. The previous slide. I think, as Dr. Badra mentioned in his great presentation, if you can access then the central part of the disc, then you go interlaminar. And the accessible fragments from the transforaminal, you can reach it like this from the transforaminal. Another important point is a learning curve is very important. We all passed through the learning curve. We tried, we stopped, then we tried again. We had courses, we went to mentors, we stopped, and we refined our work for a long time. The most important thing, which is always tell my residents and my fellows, is that when you see an expert doing, don't try to do. He took a lot of cases to reach this level. When I see Mahisha and Sukumar, for example, or Dr. Rutin in Germany doing surgeries, they finish in 5 minutes. They do cases that you can never imagine that it can be done endoscopically. So don't push the limits in the beginning. Start, as Dr. Khayyat mentioned, start with a beginner case. Give yourself safety, give yourself some confidence in the technique first, and then progress gradually, and don't jump to big cases from the start. Next, please. Yeah, I think this, Ahmed have shown this. This actually summarizes everything.
Oh.
Yeah. Last slide. This is my team. I take the opportunity to thank Dr. Sukumar, Dr. Mahisha, and this is Dr. Saeed Osman in one of the visits to my center. And it's a great opportunity to thank them live for their continuous support and help in directing me, changing my perception in endoscopic surgery. Thank you very much.
Thanks, Dr. Magdy, for the great cases, and really also thanks for the transparency, for showing also the failures you can have in the beginning, and really to see this, let's say, live on things that happened is really great, I think, for our participants, and this helps them to learn most of the things. We have one question I think it's for the plenum in general, because we will start now a little bit the discussion, okay, for all of us. For all of you, sorry. So there is Dr. Mohammad Hassanain is asking, is there a role of spinal endoscopy in translateral instability? I think he would. Translational instability.
Yeah,
I don't know the story.
About instability and diffusion, I think. Like spondylolisthesis and fusion cases. Actually, I started to do some cases of what we call endolift, which means that you put the screws percutaneously, and then you do transforaminal endoscopic discectomy, and you put some special shavers with the scope to clean the end plates and put cages. I think it is progressing, but it will take some time to reach a comparable level. I had few cases in these endolifts, maybe 6 or 5. What I noticed in my beginning cases is that the patient, they have some sort of leg pain, which is annoying them for few weeks. But this needs a big learning curve, and I had the opportunity to attend some cases with Dr. Osman. I think we need more cases and more development of instruments and cages to put some directions in these regards.
Yeah, Dr. Badra, maybe from your side, the comment on these questions?
Well, this is a very good technique and a pinning technique, and I think in the future, this is what's known as the fourth generation. You know, the third generation is the stenosis decompression. Now the fourth generation, we're talking about interbody fusion using the endoscopic technique. I think it is doable, and you need to have special instrument and like a good shavers I haven't started doing them yet. We need some instrument to be able to do them, and you need to have the expandable cage. You know, they have two problems here: the way to clean the disc properly, and the way to put an expandable cage, because you cannot put a regular cage here. You have to use an expandable cage, a small cage where you can use the working cannula to put in the cage and then expand it inside the disc space. I think this is the future. Yes, I totally agree.
Okay, thanks. Maybe also Dr. Khayyat, your comment on this?
Actually, I agree. I haven't done before. Wouldn't do this.
Sorry?
I haven't done before.
Okay, yeah. Okay, yeah, okay. But you think, yeah, okay. So coming back to the decompression, yeah, because we have some questions coming in via email. On the decompression side, from maybe Dr. Badra, you have shown us, okay, you use the decompression set, you use the big stenosis set. Is there any limit that you say in terms of, okay, from this amount of levels, I don't do this via endoscope because, I don't know, it is too hard, too long? Or do you do all of kinds of stenosis on any amount of levels?
You're talking about only stenosis cases, not disc hernia, right?
No, yeah, just stenosis cases, yeah.
You know, it's all about experience. I mean, initially we start only with one level. I mean, if I have multiple level, initially maybe it used to take me a lot of time. So I started only with one level, where actually I started with only one side, not one level, where I used to start with a lateral recess decompression only, one side. And then I moved to the both sides technique, where I do ipsilateral and contralateral over the top. And when the time, when I started to do these cases in a very short time, then I started moving to two levels cases. So you have to build up your experience to do more and more difficult cases. As Magdy said, don't start with the difficult cases initially, but start. I usually, right now, I limit my recommendation for stenosis decompression 1 or 2 levels at most.
Okay. Thank you. Yes, we have another question coming in from the audience.
Yes. Do you suggest injection of methylene blue discogram before disc removal to show the disc better?
For me, if you want me to answer, for me, when maybe at the beginning of my practice, I used it several times only in the transforaminal approach. In the interlaminar approach, I haven't used it. Of course, you don't need to use it. But for the transforaminal approach, where I'm, you know, at the beginning of my practice, I was, the transforaminal approach was new for us. Our mind is not used to look at the spinal canal from the transforaminal window, rather from the interlaminar window. So when I used to put my scope in, I used to be a little bit lost. So in order to improve my visualization of the disc fragment, maybe 2 or 3 times I used to inject dye or
indigo carmine, maybe? Or?
Indigo carmine. I used to inject indigo carmine just to, I can show you one of my cases, but with time, as you get experienced with the technique, you don't have to do it. I mean, you know where you are, and you know where are your boundaries, and you know, nowadays I'm not using this indigo carmine anymore.
Yeah.
I think all of us have started using this in the beginning because you are afraid what I'm going to see, where is the disc, because in the beginning it's difficult. But it gives you some confidence because you see a blue thing, you catch it. But actually 1 or 2 cases and then we stopped using them.
Yeah. Dr. Khayyat, what is your experience? You've passed such a long time in Germany, and we know the German perspective to it. What do you think?
Actually, I never use it. I learned from Dr. Rotten. We don't need to use it. Actually, it's very clear in the endoscope. You can recognize which nerve, which disc. So actually, I don't start. I don't do it.
Can I ask something, Robert?
Yes, please. Yeah.
Ahmed, what do you use? Always general anesthesia in your techniques?
General.
Also for
always general anesthesia.
GA. And
yes.
Mohammed, do you use general or local or epidural?
No, at the beginning of my practice, transforaminal, I used to do them local, and interlaminar, I used to do them general. Nowadays, as I get more experience with the endoscopy, I do all of them general. I'm not anymore doing local anesthesia. Initially, I used to do them local just to have a feedback from the patient regarding the exiting nerve root, because I was afraid for the transforaminal to do you need to have some practice. But nowadays, all of my cases are done under general anesthesia.
Okay, and in interlaminar cases, I have some remarks from some colleagues. They are commenting on the fluid pressure during interlaminar cases. Do you have any tricks in using this? Because they told me that they have some cases where they have some neurological insult after this because of the fluid pressure problem.
There are reports about developing seizure from increased intracranial pressure when you have a high pressure. I don't use a pump. I never use the pump, neither for the transforaminal nor for the interlaminar. I never use the pump. I never had a problem regarding neurological problem or a seizure for my patients. If I have a little bit of bleeding, I ask my assistant or my nurse to higher up or to squeeze it or to put it a little bit higher up just to have more pressure. But I never use a pump. I don't use a pump for my patients.
And especially in the interlaminar, because you and Ahmed are experts in the interlaminar. What happens?
Dr. Magdy, sorry. Can I interrupt you just at this point? This is a very important topic because also from our technical point, it's very important question. The pressure is very, very important, yeah? And this, as you described, the papers, there are enough papers that have, of course, reported problems due to the pressure because this is, of course, a very, very sensitive topic. So we have actually two technical features that are resolving this problem, yeah? And if you want to have really 100% safety, we have a pump, a dedicated spine pump that is recognizing the instrument, the optics that you use. And this pump will automatically stop the inflow to the patient when it will recognize a certain overpressure being increased inside the spinal canal, okay? So actually we have a software feature on our pump that is, of course, tailor-made to our optics and instruments. And this pump will always give you 100% safety that you will never exceed the pressure inside the spinal canal. So you will see in these papers, they have never used our instrumentation because at once is the pump and the second feature, and this is also why for Dr. Badra so far it works fine. We have an oval-shaped endoscope, yeah, that we are putting into a round sleeve. So it means between the oval-shaped endoscope and the sleeve, we have our outflow. And so we are always sure our outflow is very high and higher than the inflow. Yeah? And this is a very important point because we have, thanks to Richard Wolf, more than 100 years of experience in building endoscopes. And we have our own R&D and our own production. So due to these technical features, if you have both of them, you have 100% safety that you will have never overpressure. This is really important, yeah?
Yeah, thank you, Robert.
Yeah, okay. Please, yeah, either we have questions from the audience, maybe we will allow them, yeah? So, Tobias, please, yeah?
Yes, we have the next question regarding foraminoplasty in the transforaminal approach. Does it give, for all cases, a better outcome?
Yeah, maybe Dr. Ahmend Khayyat, yeah?
Yeah, you mean for the foraminal stenosis? Yeah, you can use only foraminotomy using the drill or the tip control, this angle drill also.
What is your preference, for example? So foraminotomy, you're referring to the radiologic controlled foraminotomy. There is a set we have that is just radiologic controlled, and then there is the foraminoplasty done, of course, by our deflectable tip controlled, where you have division of doing what you do. What is your preference?
Yeah, my preference also the flexible drill.
Okay.
Also endoscopic.
So under vision, yeah, you do this.
Under vision.
Yeah, yeah. Any comments from the others, Dr. Badra, Dr. Magdy?
I prefer to see. First, and when I feel that the facet joint is pushing me down away from the fragment, I remove with the flexible burr a piece of that to correct the cannula. But I don't feel, maybe I don't have much experience with using the burr under the C-arm control, but I think it's a nice idea and I will try it.
Dr. Badra?
Yeah, for discectomy cases, I never use foraminoplasty. I mean, I rarely use foraminoplasty for discectomy cases. I mean, when I do foraminoplasty, I mean, when you have to do it, you have to have a certain patient where you have a narrow foramen and you have to decompress. My understanding is that you have to decompress the exiting nerve root. So that's when I do foraminoplasty. But for regular discectomy, I never use use foraminoplasty or burr the foramen. Because, as I said, it all depends when you start in your at the level of the skin and where you end when you put your tip of the needle. But in most of the cases for discectomy, I never burr the bone in the foramen through using the transforaminal approach. I never do foraminoplasty.
Okay, thank you. I think we have replied to the question. I think this was a little bit the question about, whether we always need foraminoplasty or not. I think this was a little bit also the question. We have another question, which is a different topic. In terms of patient positioning, okay, what do you like, the natural prone, the slight flexion, or the very flexion? Yeah,
I always, when I have a patient, this is what I call endoscopy position. So when I tell my nurses that I put the patient in endoscopy position, I wish I have a picture to show you, but the hips and the knees should be a little bit flexed just to open the interlaminar window, especially when I'm doing an interlaminar approach. So I always not fully supine, so the hips and the knees should be a little bit flexed in order to open the interlaminar window. And this shows, I can show you some pictures where before putting the patient in endoscopy position and after, the size of the interlaminar window really changed. So yes, I do put the patient in a little bit, hips and knee are a little bit flexed.
Also in transforaminal, Dr. Badra?
Yeah, and also in transforaminal also, but not as much as for the interlaminar. But also in the same position, in the interlaminar and the transforaminal. For the transforaminal approach, even when you take a picture for the patient X-ray and you look at the iliac crest will be higher. But when you put the patient prone and you flex the hips and the knees, the iliac crest will go a little bit lower, and this will give you access to the transforaminal. So yes, I always do this, what I call the endoscopy position for the patient.
Dr. Magdy and Dr. Khayyat, yeah?
Yeah, I do the same like Dr. Badra mentioned. Exactly, flexion helps it in both situations, even in transforaminal. At least avoid lordosis, avoid hyperlordosis, but it closes everything. Lordosis closes the foramen, it closes the interspinous space. It's better to do some flexion, yes, I agree.
Yeah, actually, I do always slight flexion at the level of the pathology.
Okay. Great, thanks so far. We have now another question, let's say, which comes more from our side. I think we have seen a lot of interesting cases and interesting approaches in interlaminar and in transforaminal. And on the lumbar spine, of course, it's not the topic of today, but what about the thoracic and of course the cervical spine? Do you have already started to approach this kind of level in endoscopy? Or is it still maybe the future for you? Or Dr. Khayyat, what do you think about this? Is there any advantage you see also on higher levels?
Yeah, I don't have any experience with it, but I'm planning to start that in the future, especially for the cervical. If you have only disc prolapse in the foramen and you don't need to go anterior to remove all the discs, and you do only dorsal foraminotomy.
Yeah, Dr. Badra, maybe, yeah.
This is actually an excellent indication for endoscopy, the cervical disc. And always start, if you don't have an experience with the endoscopy, always start for the interlaminar approach at the lumbar spine, because this will give you technical skills and dexterity in using the endoscope. And then you can go higher up. When you are experienced in the lumbar, at the level of the lumbar spine using the interlaminar approach, believe me, the posterior endoscopic discectomy at the level of the cervical spine becomes easy, because when you have experience using the drills and everything, you get experience using this for the cervical spine. So yes, start with the interlaminar and then move to the cervical spine.
Yes. Dr. Magdy, you recommend the same, I imagine, yeah?
Yes, I recommend the same. The interlaminar helps you in handling the instruments, handling the burrs, because actually I'm interested in moving to the cervical, posterior cervical endoscopic, and I started already. I attended some courses immediately just before this COVID. Unfortunately, we couldn't continue another step, but I think it will move to the posterior cervical endoscopy soon.
Okay, great. Thank you so far. I think we have we have replied to all the questions from the audience. Of course, if you, dear RevoSpine Alliance members, if you have any further questions, you can also send us an email, of course, to education@revospine.com, and we can try to send them over to our dear surgeons here from the panel that assisted us, and they will answer certainly to your questions. Moreover, we are, of course, still in the pandemic situation, so the trainings is a little bit difficult, but we have many trainings that we offer apart from this kind of webinars. Yes, Tobias maybe will show you, say you a little bit about our training, about the options that we offer.
What we also can offer you is online trainings, which can be done together with our instructors locally, with a good online connection to our headquarters here, to our wet lab, where we can present our technique to you and watch your steps, your beginnings, and support you in your training. And also, please like and subscribe our videos, and subscribe to our channel. You are always welcome to be part of RevoSpine Alliance.
Thank you so much to our three invited surgeons. Thank you, Dr. Magdy from Egypt. Thank you, Dr. Ahmend Khayyat from Saudi Arabia, and Dr. Badra from Lebanon. Thank you so much for sharing your experience with us and our viewers, of course, and RevoSpine Alliance members. Yes, stay safe, and thank you very, very much.
Thank you very much.
Thank you. Thank you.
Goodbye.